All right. Hello, everyone, and welcome to today's webcast, which is about the modeling of the wrist. The outline for today is an introduction by the host. That's me. My name is Kasper Pihl Rasmussen. This will be followed by the main presentation from our guest speaker today, Dr. Jörg Eschweiler, who is the leader of the biomechanical modeling and simulation group in the chair of medical engineering at the RWTH Aachen University. And the title of the presentation today is a biomechanical wrist model for patient-specific surgical planning. After the presentation, I'm going to give some final words again, and then we're going to end off with the Q&A session. So the Anybody Modeling System is a software for making simulations of musculoskeletal systems where you get internal loads during movement. The second part is the Anybody Managed Model Repository, or the MMR, which includes generic musculoskeletal models that are contributed and maintained by researchers and us here at Anybody. There's also some special simulation features that are besides the standard features of a musculoskeletal modeling system. One example of the reaction force prediction is ground reaction force prediction. So if you don't have force plates with your mocap system, the Anybody modeling system will estimate and predict the needed reaction forces. We also have a tool for subject-specific information where you can use scans to morph your bones to make it subject-specific. The last one, man-machine interactions simulations. This means that you can import your CAD models into the modeling system easily and effectively. So imagine you have a model in SolidWorks which you then import into the system, where you then connect the human model to your CAD model and then analyze the interaction between the human body and your product. The Anybody modeling system has a lot of different applications. The most standard one is, of course, movement analysis, which could be motion capture data and where you have force plate data to run your model to get the internal forces and muscle activations. The next one, product design optimization, where you can, for example, optimize your prototype or product together with the human body. So you can, for example, find the optimal product dimension by minimizing a certain internal force or muscle activity. A bit of the same goes for ergonomic analysis, where you can study how your product or a certain task affects the body. Another application is pre and post surgery for surgical planning and outcome evaluation. And then lastly, you can also export forces from any part of the model, which can be used as load cases for finite element analysis. So the system needs two things. It needs motion and forces as an input, and then it needs some kind of muscular skeletal model, which is our body model. You also have the possibility to include some environment, which could be an exoskeleton, as you see here, or something much simpler as the ground or a tool. You merge everything together in the software, and then you run your simulation, your inverse dynamics, and calculate the muscle recruitments. So the result from this is the internal body loads. So muscle forces and joint forces. You could end here and do some post-processing, for example, use some of the forces you got to make finite element models. But you can also do this iterative design optimization loop, where you then change something in your model, run again, look how it affects your body, and so forth, to make this this optimization loop. So this is how it works, and some of the applications for the modeling system. So now I would like to give the word to Jörg. So if you hang on a second, I will make him the presenter.
Thank you, Kaspar, for the kind introduction again. Hello, everybody, and welcome to the online or web presentation about modeling of the wrist joint. I'd like to start with a short introduction of myself. My name is Jörg Eschweiler. I'm head of the group Biomechanical Modeling and Simulation at the Chair of Medical Engineering at the Helmholtz Institute here in Aachen in Germany. Here you can see our group and the group members respectively. Parallel to this, I'm also head of the group Clinic and Experimental Orthopedic Biomechanics at the University Clinic here in Aachen in cooperation with Dr. Björn Rath. With them, there exists a close cooperation to achieve valuable synergy effects. And now I want to start with my presentation. First of all, a short look at the outline and what I want to talk about. I will give a short overview about the wrist anatomy and the clinical background. Then I like to present the state of the art, and after that I start with our approach for wrist joint modeling. I like to start with an example of a possible injury. Here in the video, every one of us had seen such an accident or a similar example respectively. This situation often ends with an injury of the wrist joint. The wrist is a complex joint, and it is a collection of multiple bones and joints. Multiple motions are possible, like it is shown here on the picture on the right side. To adequately diagnose and treat carpal injuries, it is very important to understand the basic science and also the clinical relevance of functional kinematics of the wrist. This is defined as those motions that are necessary to carry out high demand activities of daily living. I want to go on with a short introduction into the anatomy of the wrist. In our case, or in our project, we focused on the carpus, which realizes a complicated set of interactions between the 5 metacarpal bones, the 8 carpal bones itself, and the radius and the ulna, the 2 forearm bones respectively. The carpus is the interface between the forearm and the hand. It bridges the hand to the forearm. Beside the bridging, and to ensure the movement of the hand, the carpus transmits the load between the hand and the forearm. The carpal bones are organized into 2 groups, a proximal row and also into a distal row. The proximal row interacts with the distal end of the radius and includes the scaphoid, the lunate, the trochanterium, and also the pisiform. The proximal carpal bones represent an intercalated segment, as no tendons insert upon them. For this reason, their movement is dependent entirely on the mechanical forces from surrounding articulations and from the surrounding soft tissue respectively. The distal row of the carpal bones is made up of the trapezium, the trapezoid, the capitate, and the hamate. The distal row articulates with the basis of the 5th metacarpal bone. The distal row is also described in the literature that it is moving as one rigid body. The carpus itself allows variable mobility of the hand, and this participates in complex articulation, which you can see here on the shown both figures. The upper figures show the motion behavior of the carpal bones during radial deviation, and the carpal motion behavior during ulnar deviation is shown on the lower picture. The proximal row is a loose fit and allows variable geometry to accommodate movements. The scaphoid and the lunate form the most of articulation with the radius. The distal row is more a tight fit, and it allows only a minimal movement between the bones of the distal row itself and between the metacarpal bones. As I mentioned before, it is described as one rigid body. In order to maintain mobility without sacrificing stability, the wrist joint has a complex configuration of ligaments, as shown here in the following images. The whole carpus is surrounded by extrinsic and intrinsic ligaments. In case of the disruption of the ligament system, this leads to changes in the individual carpal bone motion and to an abnormal load transmission. Furthermore, it leads to pain and loss of function. Yeah, that brings me to the clinical background. Up to date, the gold standard in clinical complex cases is the complete arthrodesis of the wrist joint. Further alternative interventions are the removing of the proximal carpal bones, the so-called proximal row carpectomy, where the complete bones of the proximal row were removed, or the supply with an endoprosthesis. The main problem here is often that the therapy depends on the experience of the surgeon. If we take a short look at the statistics, we see, for example, that hand injuries have a great socio-economical impact. There are over 120,000 interventions per year, where the hand and the wrist, respectively, is involved. The main problem is that there exists a high error rate in the wrist joint treatment. And also the implantation of a wrist joint endoprosthesis is not an established surgical procedure. This can be seen in the durability of the wrist joint prosthesis, which is less than 5 years in the mean. One of the most common pathways to carpal instability is the rupture of the so-called scapholunate ligament. That was the reason why we choose in our approach or in our project this pathology. We choose it for our initial investigation with our own model, but later more. The disruption of the so-called SL ligament leads to an inevitable and progressive deterioration of wrist function, the so-called scapholunate advanced collapse, short SLAC, through disruption of the normal proximal carpal mechanics. A typical sign of the rupture of the SL ligament is the so-called Terry-Thomas sign, which is shown here on the picture on the right side, on the X-ray. If the gap between the scaphoid bone and the lunate bone is bigger than 3 millimeters, the SL ligament is ruptured. We will go on with state-of-the-art in wrist joint modeling. First, there exist conceptual models which try to explain the kinematic behavior of the wrist joint. These are the so-called row model, which is more from an anatomical point of view. Furthermore, there exists the so-called column model, and a combination of the row and column model, the so-called row column model, and furthermore the so-called oval ring model. Then there exists 3 more technical models. The screw clamp model and the link joint model, and the so-called ovoid C-shape theory. But that's not all. There are also existing different computer models. These are, on the one hand, the right body spring models, which approximate the wrist joint kinematic, or the wrist joint itself, as non-deformable rigid bodies. On the other hand, there exists the so-called finite elemente models. The problem is presently that there is no existing model for therapy planning, and there is no existing patient-specific adaptable model available, and furthermore, no existing valid model. This brings us to our motivation, why we want to develop a patient-specific, adaptable biomechanical wrist joint model for computer-assisted therapy planning in wrist surgery. The idea behind is to use this developed model not only for the surgical therapy planning, so that the surgeon can preoperatively simulate the outcome of the intervention, but also for the planning of the rehabilitation to prove, for example, to prove the progress in a case and in case of differences to the to adapt the rehabilitation therapy after wrist interventions. This is part of our future work. Now I want to show how we acquired information about the motion behavior of the wrist joint. Therefore, we developed a special motion simulator combined with an electromagnetical tracking system. The motion simulator allows, in case of flexion and extension, and also in radial and ulnar adduction, an in-plane motion, and also in case of the circumduction motion, a free motion. The picture which you can see here shows an overview of our test setup. We implanted the sensors of the electromagnetical tracking system directly into the carpal bones, as you can see here on the right side on the X-rays. In comparison to other test setups, which used also an electromagnetic tracking system, our advantage was that we did not influence the initial position of each carpal bone with an additional force and resulting mechanical momentum applied from outside. For example, by connecting big sensors with a pin to the bone like it is shown here on the picture. Here in the video we see an example for the passive wrist joint movement. In our case we used for applying the motion to the wrist joint a so-called Steinmann pin, which was implanted in the third metacarpal bone. This you can see here, this one is the Steinmann pin. The pin itself was guided in a long hole to ensure that no forces from outside were applied to our cadaver hand during the motion. The outcome of these investigations was used for validating our model. Now we're going to our model setup. We built up a model of the wrist joint from the scratch. Our model includes 5 metacarpal bones, 8 carpal bones, and the 2 forearm bones. In sum, we implemented 67 ligaments. Each ligament has been approximated as a multi-string element. We also considered a physiological ligament wrapping and specific ligament stiffness for each ligament. The information for building up the model of the wrist joint came on the one hand from a database of Moore. They published a database of carpal bone anatomy, including surface models and kinematics, from a large number of CT scans of healthy subjects. We used this information as a basis for a first step for the generic morphological and functional implementation, as well as for an initial evaluation. On the other hand, we used our own investigation results, which I showed before, from our experiments with the human cadaver wrist. The difference to the kinematic information from Moore was that we acquired approximately dynamic motion trajectories. In case of the Moore database, there were only static information for the positions and orientations of the wrist bones available. To get a full motion trajectory in their case, it was necessary to interpolate between the different static positions. Furthermore, for patient-specific model adaptation, we implemented a bone morphing function. This feature allowed us to adapt our model based on image data or image information like CT or MRI scans. One part of our future work is to use ultrasound for information acquisition and respectively then for model adaptation. On the picture here on the right side, this shows a workflow for the patient-specific model adaptation. Yeah, that brings us to our simulation setup. Our approach uses a force-dependent kinematic algorithm which is implemented in the antibody software. On the left video you see the acquired physiological motion of the wrist bones, and in comparison on the right video you see the corresponding simulation results. In our mind we think that both are in good agreement. We found, for example, differences for the scaphoid, which is presented here in the figure. I would like to take a closer look to our results. Here on the left side there are shown the differences of the simulation results to the experimental data during flexion and extension. The figure shows the mean values of the deviations of the simulated motion analysis of the intact SL ligament during flexion and extension. This is the pointed line. And furthermore, the mean deviations of the simulated motion analysis with the simulated SL rupture for each bone of the proximal row. This is shown here, the crossed line. On the right side of the figure, there are shown the differences of the simulation results to the experimental data during radial and ulnar deviation. The figure shows also the mean values of the deviations of the simulated motion analysis of the intact SL ligament during radial and ulnar deviations. It's here shown by the pointed lines. And furthermore, the mean deviations of the simulated motion analysis with the simulated SL rupture for each bone of the proximal row. Furthermore, we investigated the contact areas. Slack wrist degenerative changes begin at the radiocarpal joint between the scaphoid and the radius, and progress over time to the midcarpal joint. We investigated this with our model and found a good agreement with the literature, which is here shown on the right side. On the left side you see for comparison an example taken out of the literature. Let me discuss our approach. The presented computational multi-body simulation model of the wrist joint was able to reproduce the physiological ranges of motion and also the pathological trends when compared to the experimental results. The model replicated the results of our own cadaver studies in its entirety with comparable good results for the physiological as well as for the pathological case. There exists a good correlation between measured applied stress on the forearm and also to the simulated stress application. And we have the possibility to adapt the model based on patient-specific parameters. The simulation model enabled a prediction of correct trends in physiological and pathological wrist joint motion behavior and sensitivity analysis, which could be a future tool in the context of surgical planning, and outcome prediction. Let me come to the limitations of our approach. Up to date it was not possible to consider and approximate all of the soft tissues of the natural human wrist, including skin and full forearm muscles, insertion tendons. The stiffness values of some specific ligaments have not been reported in the literature previously, so they were assigned as averages of similar ligament stiffness values. Another disadvantage was the fact that the articular cartilage was not captured by CT imaging. A reasonable first assumption was considered to scale the wrist bone linear to imitate the cartilage layers. The cartilage thickness itself is small in the wrist, such that the distance between the articulating bone surfaces was small. Here in the video, you can see the influence of the missing triangular fibrocartilage complex, which leads to a big gap between the ulna and the trochanter. And this is a problem, and it could influence the simulation. Let me conclude and give an outlook of our future work. In conclusion, obtained data from the presented wrist joint model indicate a good agreement with the available literature. However, the simulation model can be used to investigate, on one hand, pressure distributions, and on the other hand, to investigate the range of motion of wrist joint pathologies and their treatment options. Moreover, the biomechanical computational model could be used to help surgeons to get an impression of the outcome of complex operations. The next steps of our works will be a better approximation of the model to the physiological reality. In that way, that we include additional information, for example, more detailed information about anatomical insertion and origin points of the ligaments. In our mind, the result will be a more realistic model. Also, the intention is to acquire all of the needed information from the same subject, like soft tissue information and bony information, and also the individual kinematics that is part of our ongoing work. Yeah, furthermore, we will implement information about the cartilage and the missing soft tissue structures. Also, the considering of more realistic muscle wrapping will be part of our future work. So, before I come to the end, I would like to do some advertisement for our Chaos conference, which will be held here in Aachen in June this year. Please submit your papers, your research results, and join the conference, and maybe we have the chance to meet each other here in Aachen. Now I'm at the end of my presentation, and I would like to say thank you to the auditorium and to my whole team. And again, it was a pleasure for me to do this webcast. Thank you very much.
Thank you, Jörg, for the presentation. It was very nice. Before we get to the Q&A, there's just some formalities. There's no date for the next webcast, so stay tuned. We'll give you more information by email. But in the meantime, please check our YouTube channel for previous webcasts and tutorials and such. You can also take a look at our new website where you can find events, dates, publications, and so on. For all of your any scripting questions, you could go to our wiki and forum through the anyscript.org. As for events, in March, we are going to San Diego for the AAOS and ORS conferences. It is also possible now to register for Aalborg University's next Anybody course in Denmark. And then, as Jörg said, he would like to invite you to their Chaos conference in Aachen, Germany. And I should also mention that Michael Skipper Anderson from the Anybody Research Group will be presenting as a keynote speaker in Aachen. So this should be a very interesting event.